Welcome to Uniquely Spoken Podcast, empowering healthcare, where transparency sparks transformation. Are you ready to dive into conversations that will spark ideas and inspire action? This is a podcast that refuses to accept the status quo. This is episode 18, Medication Errors, Staffing, and System Failure in Long-Term Care. When we talk about medication errors and harm in long-term care, it's easy to think of them as rare, tragic mistakes, isolated incidents that happen once in a while. But the truth is, there has never been a rare problem. In fact, federal data has been warning us about harm in nursing homes for decades. Back in 2014, a major federal review by the Department of Health and Human Services looked at what actually happens to residents in skilled nursing facilities. What they found was staggering. 1 in 3 residents experienced temporary harm within just the first 35 days of care. And even more concerning, nearly 60% of those events were considered preventable. Think about that. Harm wasn't just happening. It was happening in ways that could potentially have been prevented. Medication-related events represented a significant part of that picture. This isn't new. This isn't a sudden crisis. This is a pattern. When a medication error leads to harm or even death, the first question we ask is, how did that nurse make that mistake? But what if that's the wrong question? What if the real issue isn't the individual, but why a system that has been showing warning signs for decades still exists? Federal reviews have consistently shown that harm is widespread. Yet when something goes wrong, our focus often narrows to one person, instead of examining the larger system surrounding them. Medication management in long-term care is incredibly complex. Residents often take multiple medications, sometimes more than a dozen at once. And every transition between a hospital and a nursing home becomes a high-risk moment. Research has shown that many residents arrive with medication discrepancies already present. That means the system can be fragile from the very beginning. Before a medication is even administered, risks may already exist during the transfer process itself. And that number may actually be higher because many medication errors are never reported. What's even more striking is that the system has, in some ways, normalized this risk. Federal regulations allow for a medication error rate of up to 5% before triggering violation. Just think about that. In industries like aviation or nuclear power, a 5% error rate would be considered catastrophic. But in long-term care, it has become an accepted threshold. Not because anyone wants errors to occur, but because the system has learned to live with a level of risk that would be unacceptable elsewhere. So when we hear about a tragic medication error today, when we hear about harm or even death, we have to understand something important. This isn't a new problem. It's not unpredictable. And it's not just about one person. The data has been telling us for years, decades, that harm in long-term care is both common and often preventable. This is a pattern. Now let's get into the numbers behind the outcomes, because this is where the story really starts to come together. Research consistently shows that staffing levels are directly tied to patient outcomes, including safety, complications, and death. And when staffing drops, harm goes up. Staffing shortages are not simply an inconvenience, they are directly linked to outcomes. Facilities experiencing staffing shortages have shown higher rates of adverse events and higher rates of resident mortality. The connection is impossible to ignore. Now let's put that into perspective. The average amount of nursing time available per resident is approximately 3.75 hours per day, and less than 1 hour of that typically comes from a registered nurse. Think about everything that must happen during that time: medications, assessments, documentation, emergencies, communication with providers, communication with families, staff support, all while caring for multiple residents at the same time. Every minute matters. And when you combine high workloads with staffing shortages, the risks become predictable. The connection becomes very clear. Lower staffing leads to higher workload. Higher workload leads to fatigue and interruptions. Fatigue and interruptions increase the risk of medication errors, and medication errors increase the risk of harm, and sometimes death. This isn't theory. It isn't speculation. It's a chain of events that has been documented repeatedly through research and real-world outcomes. This is not just theory. It's a pattern backed by data, repeated across studies, and seen in real-world outcomes. And yet, when a fatal medication error occurs, the focus often shifts immediately to the individual nurse. We ask, who made the mistake? Instead of asking, what conditions made that mistake more likely to happen? The research continues to point us toward the same conclusion. Staffing matters. Workload matters. Systems matter. And when those systems fail, people get hurt. The most foundational research on staffing in long-term care was conducted more than 2 decades ago. National studies examined thousands of nursing homes and directly linked staffing levels to resident outcomes. What the researchers discovered was critical. There is a threshold below which care becomes unsafe. In other words, there comes a point where there simply aren't enough people to safely accomplish everything being asked of them. And when staffing drops below that threshold, the risks increase. But here's what makes this even more important today. More than 20 years later, researchers went back and asked the same question again. Has anything changed? Have the staffing concerns improved? Have the safety risks disappeared? The answer is complicated. Because while healthcare has evolved, many of the same concerns identified decades ago are still being discussed today. The warnings remain, the patterns remain, and the need for solutions remains. When you step back and look at the full picture, you begin to see the connections: staffing levels, workload, communication systems, expectations placed on frontline staff. None of these exist in isolation. They work together. And when one part of the system becomes strained, the effects spread throughout the entire process, ultimately impacting resident outcomes. That's why medication safety cannot be viewed through a single lens. It is a systems issue. Let's step away from theory for a moment and just do the math. If a nurse or medication aide has a 2-hour window for a medication pass, that's 1 hour before and 1 hour after for a total of 120 minutes. 120 minutes. That sounds like a lot of time until we begin dividing it among residents. Now let's say that nurse or medication aide is responsible for 25 residents. 120 minutes divided by 25 residents equals 4.8 minutes per resident, less than 5 minutes. And that's before we account for interruptions, emergencies, documentation, or unexpected situations. Just 4.8 minutes. Less than 5 minutes. Think about everything that must happen during that time. Preparing the medication, verifying accuracy, confirming the right resident, the right medication, the right dose, the right time, administering it safely, documenting the administration, responding to anything that happens in real time. All of that in less than 5 minutes. That's the reality many frontline professionals face every day. But here's the problem. That 120 minutes assumes something that rarely happens in healthcare. It assumes everything goes perfectly. No interruptions, no emergencies, no missing medications, no questions from residents, no residents refusing medications, no behavioral concerns, no unexpected physician orders, no walking from room to room, no delays, no problems. In other words, a perfect medication pass. And we all know healthcare doesn't work that way. Reality looks very different. A call light activates. A resident has a question. A medication is unavailable. A physician calls back. A family member needs an update. Documentation is waiting. Another resident urgently needs assistance. These aren't unusual events. They are part of everyday practice. And every interruption adds pressure to an already limited amount of time, which means the actual time available per resident is often much less than the calculation suggests. So the real question isn't simply, how did this error happen? The real question is, how many warning signs were already there? How many risks were already known? How many system vulnerabilities already existed? How many opportunities for prevention were missed? Because most serious events don't appear out of nowhere. They develop over time. Warning sign after warning sign. Stressor after stressor. Until eventually, something goes wrong. So after all of this, the data, the history, the research, and the math, the question becomes, what do we actually do about it? Because understanding the problem is only the beginning. The real goal is improving safety, reducing harm, supporting frontline professionals, and creating systems that make safe care easier to deliver. The first step is staffing to safe levels, not simply minimum levels, safe levels. We've been studying this issue for decades, and the evidence continues to point in the same direction. Lower staffing is associated with greater workload. Greater workload increases risk. Higher staffing improves the ability to provide safe care. This isn't about convenience. It's about creating conditions where medication administration can be performed accurately, consistently, and safely. Because resident safety should never depend on whether staff have enough time to complete critical tasks. The next step is focusing on the people who are actually administering medications. In long-term care, medication safety happens at the bedside. It happens during medication passes. It happens in real-time decisions. And the professionals most often responsible for that work are medication aides, LPNs, LVNs, and frontline nurses. These professionals are managing medications, assessments, documentation, interruptions, and resident needs all at the same time. Improving medication safety means supporting the people who are doing the work, because safe systems require sufficient time, sufficient staffing, and realistic expectations. We also need to redesign the medication process itself. The current process often assumes ideal conditions: time, focus, consistency, no interruptions, no competing priorities. But the reality looks very different. Staff are interrupted, priorities shift, emergencies happen, workflows are disrupted, and every interruption creates another opportunity for error. Safer medication systems are built around real-world conditions, not ideal conditions. That means designing processes that account for interruptions, reduce unnecessary distractions, and support safe decision-making under pressure. One strategy is protected medication time, time specifically dedicated to medication administration with fewer interruptions. Because medication administration requires concentration, accuracy, clinical judgment, and attention to detail. Every interruption increases cognitive workload. Every distraction creates another opportunity for something important to be missed. Protected medication time is not about convenience. It's about safety. It's about creating an environment where staff can focus on one of the highest risk responsibilities they perform. Safer medication administration leads to safer resident outcomes, and that benefits everyone. Staffing is important, but staffing alone is not enough. We must also invest in training, support, and professional development. Medication safety depends on knowledge, clinical judgment, communication, teamwork, and ongoing competency. Healthcare is constantly evolving. New medications, new procedures, new safety expectations. Staff need the resources and support necessary to keep pace. Because the goal isn't simply to avoid errors. The goal is to create an environment where safe care becomes the standard. Perhaps one of the most important changes we can make is shifting our approach from blame to systems thinking. When something goes wrong, we often ask, who made the mistake? But that question only tells part of the story. A better question is, what system allowed the mistake to happen? Was staffing adequate? Was communication effective? Were workloads realistic? Were the necessary safeguards in place? Because most errors occur within systems, and improving those systems is how we reduce future harm. The goal isn't to assign blame. The goal is to learn, improve, and prevent the next event. These conversations shouldn't stop at nursing homes. Assisted living communities face many of the same challenges: staffing pressures, medication management responsibilities, communication challenges, and resident safety concerns. Yet expectations and oversight can vary significantly. Safety should not depend on where someone lives. Every resident deserves safe medication practices. Every resident deserves appropriate support. And every resident deserves systems that prioritize safety. Closing these gaps is not just about compliance. It's about protecting people. As we close today's discussion, let's return to the central message. We are asking healthcare professionals to deliver precision, accuracy, clinical judgment, and safety, often under significant time pressure, often while managing competing responsibilities, often while working within systems that are already strained. Medication errors are not always the result of one individual. The data tells us a much larger story, a story involving staffing, workload, communication, expectations, and system design. Because in the end, this isn't just a staffing problem, it's a systems problem. And until the system changes, the outcomes won't either. Thank you for joining me for episode 18. Until next time, continue advocating for safer care. I am Juanita, the founder of Uniquely Spoken LLC. I started this podcast to ignite change in healthcare, starting with long-term care settings. It is time to transform nursing homes and rehabilitation centers, assisted living, and memory care communities to all become premier long-term care settings nationwide. It is time for all long-term care settings to receive a 5-star quality and customer service rating. It starts now, and it starts with me. It starts with you, you, and you. And the time is now. Thank you for joining us. We broadcast every Tuesday at 8:30 a.m. Eastern Standard Time. Don't forget to join the conversation, request to be a speaker, and partner in transforming long-term care settings. And don't forget to tune in next week. Thank you for joining us on Uniquely Spoken LLC podcast. Please subscribe on Spotify, Apple Podcasts, or wherever you listen. Remember to connect with us. Follow, comment, subscribe, share, be a guest. Visit us at uniquelyspokenllc.com/podcast. That's UNIQUELECPOKENLC.com/podcast. Or if you are a viewer, scan our QR code. Please remember to stay informed, stay empowered, and keep the conversation going. We love hearing from you, and we'll see you next week.